and welcome to this episode of A Cancer Conversation with the Georgia Cancer Center. I am your host, Chris Curry. I am the Communications and Marketing Manager here at the Georgia Cancer Center at the Medical College of Georgia at Augusta University. In today's conversation, we're going to be covering a series of topics related to colorectal cancer. March is Colorectal Cancer Awareness Month, and joining me for today's discussion, we have Dr. Ken Vega. Dr. Vega, thank you for joining me today.
Thank you, Chris. It's a pleasure to do so.
Absolutely. You are the Chief of Gastroenterology here at the Medical College of Georgia, and we could say that you work with a team when it comes to being on the front lines in the fight against colorectal cancer, because your team, that team is responsible for finding what could be cancer and referring it for further testing and possible treatment at the Georgia Cancer Center.
Exactly right. I mean, we actually perform the colonoscopies that patients should have starting at age 45 for the most part. And we find polyps that are very small that, had they stayed, could turn into colon cancer, or big ones that are much closer on the way to cancer. And unfortunately, even patients who have cancer, and we can try to remove it, preventing them from having surgery. Finally, if we find something that's not available or not amenable for us to do surgery, then we refer to our surgical colleagues for them to do their thing and remove the cancer.
Let's talk about you first. Before we get into that topic a little deeper, let's talk about you and your passion for working as a gastroenterologist. What made you feel like this was the right opportunity career-wise for you?
Well, as a young trainee, I got a chance to do a month rotation in gastroenterology, and I found that doing procedures was something I liked to do. It was enjoyable. I didn't know my video game skills in college would help me in my career.
Yes.
And then being able to see directly the results of what you do. You find a big polyp, you take it out, you send it to pathology, they look under the microscope and they find that it has cancer at the tip, not at the base. You've just saved somebody's life. I have multiple episodes of that happening to me in my career, and actually one where I have a long-standing friend on Facebook now for 22 years. I found multiple polyps like that. Luckily, he got them all out, and he always sends me a birthday greeting on Facebook every year.
That's awesome.
It's
so
really cool.
Really a lifelong friendship.
Exactly, from that.
Talk a little bit about the video game of it all. How did those skills help you transition into working as a gastroenterologist?
Well, imagine playing a flight simulator on your computer. You're doing something on a 2D screen, but it's actually in 3D because you have to worry about dimensions forward and to the sides. But your mind's interpreting what you see on the screen in 3D. What we do with colonoscopy is very similar. And so when we're looking at a 2D screen, we're using our mind to make it three-dimensional so that we can figure out how the best way is to approach removing a polyp, how to do it safely, how to do it easily, and those skills translate very well. I've had trainees that have struggled with their endoscopy skills practice on a flight simulator, microscope flight simulator, or a World War II flying program, and have done well.
Wow.
The mind clicks. It's just getting the mind to think that way.
Okay.
And then you can get them to do the other stuff easier.
That's awesome. Let's talk about the different ways to screen for colorectal cancer now. I know you talk a little bit about colonoscopy, but that's not the only way. I know some of them can be done at home while others do require an expert touch like yourself.
That's true. That's true. Any test, the one thing I'll say is any screening test is better than no test at all. And there are at least two ones that you can do at home. One is called a FIT test, which checks for blood in the stool.
Okay.
And then another one is a more, I won't say more advanced test, but a different test that also looks for genetic markers. And you probably know that from seeing that blue box that talks to you on TV commercials.
Yes, I have seen that.
Called Cologuard.
Yes.
And that's another test. They vary in price and vary also with regard to insurance coverage. Both of those tests could be done if you didn't want to have a colonoscopy to start, but if they're positive, that leads you down the road to colonoscopy.
So you're going to have to get a colonoscopy anyway.
Correct. If they're positive, you would get a colonoscopy. If they're negative, then depending on which one you choose, a FIT test would need to be done every year.
Okay.
A Cologuard test would be done every 3 years.
Okay.
Also, those are only for patients that are average risk. So if you have a family history of polyps or a family history of colon cancer, and like a mother, father, brother, sister, you're in a different category. You should only really have colonoscopy as your screening test.
Let's talk about those different categories. How important is it for patients to understand the different guidelines and the ages of when to start a colonoscopy?
Very, very important, especially with the alarming trend recently reported of an increase in young colon cancer, people around the age of 45 or even less. And so knowing your family history changes when you start screening and how often you get screening. So, for example, my brother has a history of polyps. That puts me in a higher risk category.
Okay.
I'm on, for lack of a better term, the 5-year plan.
The 5-year plan.
The 5-year plan.
Okay.
Now, if you come in and you don't have a family history, but you're found to have one polyp that could have turned to cancer had it stayed, that puts you on a 7-year plan.
Okay.
If you have more than 3 smaller polyps, that puts you back in the 5-year plan.
Okay.
And if you have really bigger ones, that puts you on a 3-year plan to start, but can change over time.
Okay. And I understand there have been some changes in recent years about the age to start screening and when that should happen. Can you share the latest ages or age ranges for us?
Of course. Right now, for average risk people, the age to start is 45.
Okay.
If you have a history of colon cancer in your family, and it's a young individual, so let's say someone had colon cancer at 42, then you would start your screening 5 years earlier than the age where the person was diagnosed.
So that would be
37.
Okay.
Correct.
Okay. Why do we know why colon cancer is starting to show up more often in younger people? Is there any sort of reports?
I think there's data showing the trend. The question is, why is it happening? Could it be related to the obesity epidemic in America? That's true. Could it also be related to the American diet compared to other parts of the world? I think that's also a contributor. How much each plays in the role, as well as your own family genetics or the lack of knowledge of your own family genetics plays a role, there's probably multiple reasons, and we're trying to flesh things out.
Okay, good. What is it like for you to work with patients undergoing a colonoscopy? I know it sounds like not the funnest procedure, but you and I have talked in the past, and I know you, sort of have a really good process when it comes to working with patients undergoing a colonoscopy.
Well, having had the procedure 3 times myself and being due in 2024 for my 5-year plan visit,
Okay.
You get, I think, translating that personal experience with the preparation, with what the procedure does, how people get sedated, I think is important when you're meeting someone to talk about colonoscopy initially. And then making sure that they know how to get themselves cleaned out so that they only have the procedure once and not have to come back a second time because we can't see everything that we should. Finally, also accounting for the support individuals that are going to be coming in to bring your patient to the procedure and take them home. You have to be considerate of their time too. And that's why making the procedure successful the first time is beneficial to everyone involved.
What does that prep process look like, and how has it changed over the years? I feel like I've read some reports in recent years that there's been some changes in how the preparation for a colonoscopy goes.
That's right. It has changed. When I had my first one, for instance, you would get a big jug of a gallon jug of powder you'd mix it up with water. They'd give you a certain flavoring to add. It made it taste worse. And really the plain stuff tasted to me like salt water, like when you went swimming in the ocean and got some water to swallow.
Yes.
Awful.
That has happened to me a number of times in the beach.
And
yes.
so that doesn't feel very good. Luckily, I'd say within the past 5 to 7 years, we've changed. There's an item you could buy in a store called Miralax.
Okay.
Doesn't have any taste to it. You mix it in Gatorade, Powerade, or Allsport, and then drink it the day before. Combined with that, you should also do a liquid diet for at least 1 day, if not 2, to make sure you get all the leftovers out.
Okay.
And then it makes it easy for me to see, makes it easy for me to go around, makes it easy to find small things as well as take out big things that I find because there's nothing in the way.
And how important is that during a colonoscopy to be able to see everything and move around freely because the patient did their prep the right way?
No question, it helps us find smaller lesions and be able to remove them easily. Also, bad preps mean things can be hidden from us that we don't see and could not be noted on the initial exam, but be there and still growing on the sequential exam, and you wonder why, hey, I had a colonoscopy, they didn't find anything. But if you couldn't see everything well, there's something hiding and could be developing under that.
What do you think is most important to let people know about during March and Colorectal Cancer Awareness Month? If you could give one message, what would that be?
Any test is a good test. If you're not interested in colonoscopy to start, at least do either the FIT test or the Cologuard to make sure that you're getting screened in some way. If it's negative, then you can wait another year or 3 years, depending on the Cologuard, for it to be repeated. Also, if you've had those tests but developed things that are changes that would make us worried that something's going on, like a change in how you move your bowels, a change either too fast or too slow from your normal. If you ever have an episode of rectal bleeding where you turn the toilet water red, that should prompt you to see your primary care doc. And then lastly, if you're losing weight and you don't know why, those are all what we would call alarm features that should bring you to your primary care doc and get you to see someone like me.
And it's really important that you and the patient both work with the primary care doctor, because that person, him or her or whatnot, can be sort of that first line of like, all right, we need to take a deeper look at this before something else develops.
No, that's exactly right. I mean, when I do a procedure, one of my first things after completing the procedure is sending the completed note to the referring doctor, so they have it within literally minutes of me finishing the note. And if they have a mass or cancer or something that I think is cancer that needs to be sent to Dr. Farkas, for instance, I would actually contact Dr. Farkas right after I complete the procedure to try to get the patient tied into her services. In addition, it makes sure that the loop is closed for the patient. So having appropriate follow-up schedule that the primary care doctor knows, Dr. Farkas knows if she needs to be involved, and the patient knows that we're not leaving them to the winds and not knowing what to do, where to go, who to talk to.
Yeah. Well, Dr. Vega, I appreciate your time today to be part of this conversation. I know you have a strong commitment to working with our patient population and also offering information so that these patients do feel comfortable and prepared the right way for their colonoscopy. So thank you for what you do. I appreciate you being here today.
No, thank you for having me, and thank you for allowing me to help educate our patients so we can do it right and do as many as we can.